Good morning and welcome to my basement. This is my first virtual lecture on vertigo in 69 years. In fact, this is my first virtual lecture in anything in about 69 years. Now, who's this guy in front of you right now? This is Mike Tyson, one of the toughest, heaviest punching professional boxers in the history of boxing. He was tough and an expert on vertigo, obviously. And here's what Mike Tyson said about vertigo. Everyone has a plan until they get punched in the mouth. And I'm going to do something about this because Mike was right. Now, I care about your teeth. I care about you. I mean, 2020 has been absolutely a challenge. And I care about your patience. And we're going to solve this vertigo problem right now. There's nothing vague about this talk. I'm going to be clear, compelling, memorable, and hopefully entertaining. Now look at that. Man, expect the unexpected. The price of gas was 0 cents when I was there a couple of weeks ago. Of course, there was no gas. Now, here's the question. Here's the challenge of vertigo. Is the patient staying or are they going home? Is it a stroke or is it acute vestibular neuritis? This is the challenge. So do I have any conflicts in this area? Well, nothing about Bitcoin, obviously. But I do have a personal experience, which is a conflict for me. 99% of MDs I meet are not awesome at hints, yet the evidence suggests the hints test is amazing. Is there a problem? Here are my goals. I'm going to define dizziness. I'm going to talk about the attest. The attest is the best acronym to solve the problem of vertigo. I'm going to discuss the acute vestibular syndrome. The acute vestibular syndrome basically has two diseases: stroke presenting as vertigo or vestibular neuritis. I'm going to talk about the hints test. So what is dizziness? Dizziness is disturbance of spatial orientation. It's really hard to describe. Vertigo is a sense of movement, rotation, swaying, linear movement. And quite often we ask a patient, tell me about your dizziness. Tell me about your vertigo. We spend far too much time trying to determine the kind of dizziness. Try to figure out if it's vertigo or presyncope. Don't spend too much time on it. The most important aspects of vertigo are not the description of it, which is very difficult and highly variable. It's the trigger and the timing. The trigger and the timing. And I'm going to use the term vestibular neuritis, vestibular neuritis, and probably inappropriately labyrinthitis interchangeably. Now, here's the challenge. When you work in an emergency department, 3 to 5% of your patients have dizziness. And of those 3 to 5%, a subset of 3 to 5% have serious causes for dizziness. And you don't want to miss a stroke presenting as isolated vertigo. That's the challenge. So, listen up. I was taught none of these things. We now know that isolated vertigo with mild imbalance can be a TIA. Isolated vertigo can be a stroke. Now, obviously, with some nausea and vomiting and nystagmus, but with nothing else, that can actually be a stroke. I was taught this was not possible. And here's a challenge about missing cerebellar strokes. 1/4 of strokes are in the posterior circulation. A large number of them involve the cerebellum. And if you send home a person with a cerebellar stroke, which is not difficult to do in the first 24 hours or so, a large minority of about 1/4 will get cerebellar edema in day 3 and have a very bad outcome. And it's often not foreseeable. So here's a very important question. Listen up. Which is true? Isolated vertigo can be a stroke. Have you been listening? Is that true? Isolated vertigo can be a TIA. Is that true? I was taught no, it's not. Unidirectional nystagmus, which means if you look to the right, your eyes beat to the right. If you look to the left, your eyes beat to the right. Can that be a stroke? I was taught if it's unidirectional nystagmus, it's always peripheral. The HIT, head, impulse test. I was taught that if you took the person's head and moved it to one side, and if their eyes moved with the head and then corrected, that's a corrective saccade, I was taught that was always peripheral. Is that reliable? The Hintz test. We've been taught the Hintz test has 100% sensitivity for a stroke. Is that true? Well, I'll tell you which one of these is true. Isolated vertigo can be a stroke. Isolated vertigo can be a TA. Unidirectional nystagmus, surprisingly, can be seen in some strokes. The corrective saccade, which is supposed to be peripheral, can actually occur in some strokes. And the head impulse test, the Hintz test, in the hands of the emergency doctor is very suspect. These are all true, and they're all contrary to what I once believed. Now, you don't want to miss a stroke. So if a 75-year-old or 80-year-old patient presents with vertigo and their gait is disturbed, there's a reasonable chance that vertiginous person is actually having a stroke and not vestibular neuritis. But here's the trick. Young patients get strokes. 20% of strokes occur in patients under 50 years of age. Now, how is that possible? Patent foramen valleys and vertebral artery dissections. Don't be fooled by youth. Now, a test is an acronym. It stands for associated symptoms, A, T for timing, T for trigger, ES for examination findings, examination symptoms, and T for special tests. A test. A test is the acronym to understand the investigation in clinical investigation of vertigo. Associated symptoms, trigger, timing, examination signs, and tests. I hate acronyms. I can never remember them. This is the one acronym I tend to use. If your patient has associated symptoms, your vertiginous patients have the Ds, diplopia, dysarthria, dysphasia, dysmetria, it's a stroke. If your patient has pain in the neck, consider dissections. Pain in the head, consider stroke. Motor or sensory findings, cross-sensory findings, consider a stroke. And if your patient cannot walk without assistance, the risk of a stroke increases dramatically. If they're mildly imbalanced, more likely vestibular neuritis, but not necessarily. But if they have to hold on to a tabletop, if your patient cannot even sit up, this is substantial ataxia, makes a stroke much more likely. And how about ataxia without nystagmus? Well, acute vestibular syndrome must have nystagmus initially. Ataxia without nystagmus, well, that makes a stroke much more likely. So the trigger, that's interesting. We know if the person rolls over in bed and suddenly has vertigo and remains perfectly still and it's gone in a minute, that's BPPV almost without fail. If it's triggered by movement, it's probably positional vertigo. Although all vertigo is made worse with movement, positional vertigo only occurs with movement and goes away when the person remains perfectly still. Now, a TAA has no trigger, a migraine or Meniere's has no trigger, and acute vestibular syndrome has no trigger. Now, every neurologist will tell you timing is everything. So the next slide is important. Timing is everything in neurology. It's probably everything in life. The next slide is important. If the vertigo lasts for under a minute, and the patient remains perfectly still, and pretty well abates by a minute, this is BPPV. TAAs presenting with isolated vertigo and nausea and vomiting tend to last 5, 10, 15, 20 minutes. People with migraines, 1/5 of them get vestibular migraines. A vestibular migraine is a migraineur who presents with recurring episodes of vertigo lasting an hour or 2 hours or 3 hours. Phenomenally common and underdiagnosed. And Meniere's disease, pretty rare. But people with Meniere's disease often present with vertigo lasting hours. along with tinnitus and eventually hearing loss. But here's my advice to you. Don't be the first brilliant emergency physician to be the first one to diagnose a new case of vestibular migraine or Meniere's disease in the emergency department. You may well be right, but occasionally you're going to be dead wrong. An acute vestibular syndrome, which is basically two major diseases, vestibular neuritis and cerebellar or brainstem stroke, gives you vertigo lasting more than 24 hours. Although they present early, before 24 hours, you're never really going to know how long it's going to last. So a test, associate symptoms, trigger timing, and examination signs. Check the HINTS test, which I'll get into in a moment. Look for ataxia. Class 1 means they're slightly imbalanced, but they can walk, makes a stroke less likely. Class 2 means they've got to hold onto a tabletop, makes a stroke more likely. Class 3 means they can't even sit up, makes a stroke more likely. Now, I was taught if there's an acute hearing loss with vertigo, it's got to be peripheral. Not true. If there's acute hearing loss with vertigo, it's probably a stroke of the anterior inferior cerebellar artery. Now, tinnitus can be a warning stroke, and tinnitus, of course, can be Meniere's disease, and do a neuro exam. What tests would you do? Well, a CT scan of the head is a very poor test to diagnose an early posterior stroke. In fact, the sensitivity is terrible for posterior strokes. An MRI in the first 24 to 40 hours will miss 48% of posterior strokes in the cerebellum and brainstem. But a CTA and an MRA is a useful test to investigate high-risk TIAs and to investigate dissections. Now, Ken Milne, the host of Skeptic's Guide to Emergency Medicine, has a beautiful recent podcast on vertigo. Here's what he tweeted out just a few months ago. He asked emergency doctors, are you comfortable performing the HINTS test? Look at the results. 19% said yes. I thought it was going to be 0.1%. 62% told the truth. No, I'm not comfortable. And 18.4% were totally truthful. What is a HINTS exam? Acute vestibular syndrome is characterized by acute dizziness, nausea, vomiting, nystagmus, at least initially, unsteady gait, intolerance to head movement. And it lasts more than 24 hours. Now, how often do you see acute vestibular syndrome emerge? Maybe 2, 3, 4, 5, 6 times a year. But this is the thing we're always worried about. Not vertigo for a minute, but vertigo for hours, sometimes lasting a day or two. What do you do with these patients? Is it a stroke or is it vestibular neuritis? Well, here's a challenge. If you do a CT scan on patients having a stroke in the posterior circulation, the sensitivity is 16%, which is awful. Do I do CT scans in these patients and worry about a stroke? Yes, I do. Useless test, sort of. How about an MRI in the first 24 to 48 hours? It's better, but not good enough. Only has an 80% sensitivity. Even MRIs have false negatives for cerebellar and brainstem strokes. It's not good enough. So is there a solution to not getting punched in the face by Mike Tyson, well-known vertigo expert? Yes, there is. Now, listen up, because here's solution number 1. We know that between 10 and 20% of patients with dizziness and ED have acute vestibular syndrome. You might see maybe 1 a month. Dizziness, vertigo, and nystagmus. You might see 1 every 2 months. We know 25% of those patients have a stroke. So let me give you 1 solution. You see a patient with vertigo, it's lasting for hours, they've got nystagmus, you're not sure about the HINTS test, their gait is sort of not great, and you think, well, they probably have vestibular neuritis. But you now know a quarter of these patients have a stroke. I'm going to give you a perfectly good option. Refer them for admission. Say to the consultant, you know, this person's got acute vestibular syndrome, they've got nystagmus, not sure about the HINTS test. And you know, the literature says that 25% of these patients have a stroke. I'm not comfortable sending this person home. In fact, a lot of internists aren't comfortable sending these patients home. And you could take the option of referring every one of these patients for admission. How often would that happen? 4 or 5 times a year if you're a busy emerge doc. And that's an option. You're never going to send home a stroke accidentally, at least in the realm of acute vestibular syndrome. So, as I said, if 25% of acute vestibular syndromes have strokes, and if you see 4 or 5 of these patients a year with vertigo and nystagmus, not BPPV, vertigo lasting a minute, you could admit them all. Or you could be brilliant and check for vestibular neuritis and send some home, which I will discuss in a moment. And I'm not saying brilliant is smart, but it is an option if you're very skilled and confident. So what would Alfred E. Newman do? You remember Mad Magazine, the best political satire magazine in America? Here's what Alfred E. Newman would say. Me worry? I've got a patient with acute vestibular syndrome and nystagmus and gait imbalance. I'm referring all of them. I don't like to worry. It's an option. Now, let's say you're an expert. Well, here's what you do. You determine in your mind that the patient has peripheral vertigo, otherwise called acute vestibular syndrome. That impulse test has a corrective saccade. You turn their head, their eyes move with their head, and they have a corrective saccade, that's peripheral. And their nystagmus is unidirectional. And the test of skew, cover one eye and the other eye and the other eye. The eyeballs move up and down. Test of skew is negative, and they have no deafness, because sudden deafness can be a stroke. And they have minimal ataxia, minimal. If all those criteria are met, the likelihood of acute vestibular syndrome being caused by vestibular neuritis is pretty good, and they can go home with a good follow-up. That is an option. So here's the most famous paper about the Hintz test, 2009, the first of many. Here's what the paper said. The Hintz test is awesome. It's 100% sensitive for stroke. Now, you know that evidence-based medicine is a bit like uranium. It's very powerful, but misused, it can be dangerous. The Hintz test in this paper was performed by highly trained experts in neurology. So it's true, we're highly trained experts in neurology, which these people rarely appear in emergency departments. So the next 2 slides are shocking. Be prepared. Shocking things happen. These 2 papers have been published in the last couple of months. September 2020, Academic Emergency Medicine. This was a meta-analysis published by a group of doctors in Canada, the Northern Ontario. 5 papers were evaluated, including the paper I just discussed. Here was their conclusion. The Hintz test in the ED is not sufficiently accurate to rule out a stroke. I've suspected this for 10 years, actually. Finally, I was vindicated. Now, April 2021, how long ago was that? This was published in Academic Emergency Medicine, Northern Ontario, the Northern Medical School in Ontario. 2,000 dizzy patients over 4 years. The Hintz test was used inappropriately 97% of the time. Wow. Completely consistent with my observations. Central vertigo, everyone was missed. What was their conclusion? Additional training of ED physicians may be required. That's pretty benign. So, conclusion to vertigo. What do you do about acute vestibular syndrome? Here's my plan. Even if you get punched in the face, you're going to be pretty good about it. Your patients will be well looked after. Who stays in the hospital? If the Hintz test has even one positive feature for a stroke, if they have a headache or neck pain, or if they have hearing loss, or if they're elderly with significant vertigo and ataxia, or if they have significant risk factors for a stroke, or if they have any ataxia other than trivial, any of these are present, I think it's reasonable to refer them for admission and investigation. Who goes home? Not too many people, because a quarter of acute vestibular syndrome is having a stroke. Now, I didn't say a quarter of all dizziness. I'm talking about a quarter of acute vestibular syndrome is having a stroke. If you do an excellent neuro exam, you're confident in your Hens test, you're confident they have all the peripheral findings of vestibuloinitis, you consider giving them aspirin because it's the best treatment for a TAA and the best treatment for a dissection. You might get a CTA in the emergency department if you're worried about a high-risk TIA or a dissection. If you give them excellent advice and early follow-up, these are the folks you might send home. Now you know exactly what to do about vertigo, how to use the attest, need to be careful. You know all the misconceptions we've been taught, and be careful with the Hens test. Thank you. Remember, a person has to know their limitations.